Good afternoon and welcome to the first Care Partner Learning Series webinar, Navigating Behavioral Variant FTD. I'm Ann Schoonover, AFTD Helpline Specialist. On behalf of AFTD, I thank you all for joining us. Please note that our audience will be muted throughout this webinar to keep background noise to a minimum. If you are experiencing any technical issues, please write a message in the questions box and a member of the AFTD staff will try to address them. You can also use the questions box to submit questions for our presenter throughout the webinar. There will be a brief Q&A portion of this webinar where we will answer as many questions as we can. Feel free to submit your question as it occurs to you. You don't have to wait until the Q&A portion to ask your question. Additionally, this webinar will be recorded and archived for later viewing on AFTD's YouTube page. And before we get started, I wanted to let you know that AFTD is hard at work planning our 2025 Education Conference, which will take place Friday, May 2nd, outside Denver, Colorado. This annual conference brings together people affected by FTD, experts in the field, and other healthcare professionals for a full day of learning and connection. If you can't make it to Colorado, you have the option of following along with our free live stream. Additionally, most sessions will be recorded for later viewing. Visit the link displayed on your screen to sign up to be notified when registration opens early next year. And now it's my pleasure to introduce today's expert presenter. Dr. Katya Rascovsky is an associate professor and neuropsychologist in the Department of Neurology and Penn Frontotemporal Degeneration Center at the University of Pennsylvania Perelman School of Medicine. For the past 20 years, Dr. Rascovsky's research has focused on identifying the cognitive and behavioral markers of behavioral variant FTD. She was a leader in developing the international consensus criteria for diagnosing bvFTD, published in 2011. Her research also includes studies of survival and clinical progression of patients with FTD. Dr. Rascovsky is also a native Spanish speaker and has broad experience in research and care of Latino dementia patients, both in Latin America and the United States. She has a clinical interest in young onset dementia, traumatic brain injury, and the cognitive assessment of Spanish-speaking patients. And with that, I would like to welcome Dr. Rascovsky to the screen for her presentation.
Hello, everybody. Can you hear me? Okay, fantastic. Thank you so much to AFTD for the invitation. It's really a pleasure to be here this afternoon. And today we're going to talk about navigating symptoms in behavioral variant FTD. Next slide. Okay, so here's an overview of what we're going to talk about today. First, I'm going to give you a brief introduction into the FTD spectrum. Then we will delve deeper into the most common FTD presentation, which is the behavioral variant of FTD. Then we will talk about the behavioral symptoms with particular focus on disinhibition and lack of insight. And then we will talk about the cognitive aspects of bvFTD. And finally, we will touch on some strategies to manage these cognitive and behavioral symptoms. Next slide. So before we talk about FTD, I want to orient you a little bit in terms of the different areas of the brain and what they do. Now, obviously, the brain is an infinitely complex organ that works in networks. However, certain parts of the brain are more heavily involved in certain functions. So starting from the back in light blue, we have the occipital lobe, which is involved in vision. And on the top yellow, the parietal lobe, which is involved in touch and visual spatial abilities. The temporal lobe in green is involved in hearing, understanding of language. And in the middle, we have structures that are involved in memory. Now, what you see in red are the frontal lobes. That is the most evolved part of our brain. The back of the frontal lobes are involved in movement, and the left side in the expression of language. Now, the very front part is involved in what we call executive functions, such as attention, organization, planning, problem solving, judgment, and inhibition. The frontal lobes are also crucial for social behavior and personality. Now, FTD refers to a group of brain disorders caused by a loss of neurons or degeneration in the anterior parts of the frontal and temporal lobes. So if you were to look at the brain in the section that is depicted in the diagram to your right, we would see shrinkage or atrophy compared to a normal brain. Now, depending on where the atrophy develops, we will see a gradual deterioration of behavior, language, or movement with relative preservation of memory and visuospatial functions, which are more associated with areas in the middle and posterior part of the brain. Next slide. All right, so what do we know about the spectrum of frontotemporal degenerations? We know that they're relatively rare disorders. We estimate that in the US, there are about 60,000 people living with FTD. Now, the fact that it's rare makes it difficult to diagnose, as a lot of providers are not familiar with the disorder. It has a younger onset compared to other dementias, with an onset usually between the ages of 45 and 65. And we know it is a spectrum of disorders that differs in terms of clinical presentation and survival. And the disease course is usually associated with the clinical presentation and whether or not it is accompanied by movement disorder. Next slide. All right, so let's clarify some terms. So currently, most researchers talk about frontotemporal dementia or FTD when referring to the spectrum of clinical syndromes, that is how they present, and frontotemporal lobar degeneration only when referring to the underlying brain pathology, that is the changes that we see under the microscope. So currently, we classify FTLD on the basis of the protein abnormality, which is thought to cause the disease or is most characteristic. So 90 to 95% of FTD cases fall into one of two categories: FTLD associated with misfolded tau proteins, or FTLD with inclusions of a protein called TDP43. Now, today we're going to be talking about behavioral variant FTD, and that is just as likely to be one or the other, tau or TDP. It presents the same way because of where the atrophy is located, but the underlying cause is different, and so this will have implications once treatments become available. Next slide. All right, so FTD can be genetic, which means that it runs in families, or it can be sporadic, so where we don't have an identifiable genetic or environmental cause. FTD is estimated to be familial in about 20 to 25% of patients, and most are caused by mutations in three genes: tau, progranulin, and C9orf72. Now, if you have a family history of a similar disorder, we always recommend that you talk to a genetic counselor if this is a topic of concern. Next slide. All right, so as we already mentioned, FTD can present in a variety of ways. They can present as a gradual deterioration of behavior, language, or movement, depending on where the atrophy is most prominent. Now, the diagram on the left shows you the spectrum of different clinical presentations, and the one on the right shows you the corresponding atrophy. Now, very briefly, within the cognitive syndromes, we have the behavioral variant FTD, which is what we're going to talk about today, as well as the progressive language syndromes that are also known as primary progressive aphasias, or PPA. Within the PPAs, we have a semantic variant, where patients have difficulty understanding language because they lose the meaning of words and objects, and a non-fluent agrammatic variant where patients have difficulty with expressive language, speech, and grammar. Now, within the movement disorders, we have three main syndromes, including FTD with ALS, so Lou Gehrig's disease. Now, if you want to learn more about these syndromes, please go to the AFTD website. So we're talking about bvFTD. Why go through the different clinical presentations? Next slide. Well, depending on where the atrophy develops, patients may initially present with one clinical syndrome, but eventually develop features of the other syndromes as well, as you can see by the many overlaps in this Venn diagram. So for the purpose of this talk, I will focus on the primary behavioral syndrome, but keep in mind that it can co-occur with language and motor symptoms. In FTD, although there are similarities, every patient is unique with his and her own specific constellation of symptoms. That is why diagnosis and management can be difficult because we really do need an individualized approach. Next. All right, so now that you have a broad idea of the FTD spectrum, I'm going to focus on the most common clinical syndrome, which is the classic behavioral variant of FTD. Next slide. All right, so let me show you what the atrophy looks like in bvFTD. Now, these are MRI scans of the brain, and in green and in orange, you can see this prominent frontal and temporal atrophy at a group level. And just to give you some perspective, on the right bottom panel, you can see the atrophy in a single bvFTD patient compared to a normal brain. So at the earliest stages of disease, atrophy is confined to the middle and bottom parts of the frontal lobes, and then the atrophy spreads to more lateral and posterior parts of the brain. So given this pattern of progression, it's not surprising that the first thing that we see in patients with bvFTD is a marked alteration in behavior. Next slide. Okay. So let's talk about behavioral symptoms. Now, there are a constellation of symptoms that make up the syndrome of bvFTD. And again, every patient is different. As I go through the different symptoms, I just want to be aware of some of the wonderful resources AFTD has put together for patients and families, so you can learn more about each symptom and how to manage it. So if you're interested in learning more, you can go to the Find Support tab, then click on Managing FTD, and then you will find a list of the different symptoms and ways to cope. Next slide. All right, so let's start with disinhibition. So early behavioral disinhibition is a hallmark feature of bvFTD, and it presents in about 76% of patients at initial presentation. Now, while other symptoms such as apathy can be more frequent, disinhibition is more specific. That is, it discriminates bvFTD from normal aging, Alzheimer's disease, and other dementias. Disinhibition and impulsivity present early in the disease, but tend to decrease as the disease progresses. Now, there are many ways to define disinhibition, but I particularly like the definition provided by Dr. Mario Mendez and his colleagues at UCLA. So he defines disinhibition as unrestrained behavior with disregard for rules or consequences. He further divides disinhibition into person-based disinhibition and generalized impulsivity. And in very simple terms, person-based disinhibition includes inappropriate interactions with people, and generalized impulsivity pertains to behavior that may or may not be performed in a social context. So let me give you some examples. Generalized impulsivity refers to impulsive, rash, or careless actions. These include reckless driving, nuanced gambling, buying or selling objects without regard for consequences, or indiscriminate sharing of personal information, such as credit card information, social security number. These actions may or may not be performed in a social context. That is, a person can gamble or drive by themselves, right? They don't have to be with people. Now, person-based disinhibition includes socially inappropriate behavior and loss of manners or decorum. So examples of behaviors that violate social norms include a range of behaviors like inappropriate laughter, cursing, loudness, offensive jokes or opinions, or crude or sexually explicit remarks. Patients may also display a lack of etiquette. So for example, failing to wait in line, or eating with their mouth open, or a loss of respect for interpersonal space. Now, making the determination of whether someone is behaving inappropriately can be difficult because behavior is normal or abnormal depending on context. For example, if I tell a dirty joke in front of my friends, that might be okay. But if I do it in the context of professional talk, that might be career limiting. And whether behavior is appropriate also depends on culture. What is appropriate in a liberal society may not be permissible or appropriate in a very conservative society. You also need to take into account how the person was before the symptoms started. So it's easier to make the call when the change is salient. Like, for example, someone was very proper and introverted, and then suddenly starts being very loud or making offensive remarks. Now, before I move on, I want to mention hypersexuality, just to acknowledge that it can happen, and that it can be very difficult for care partners to talk about. There are really two types of hypersexual behavior. A lot of what we see in bvFTD is really opportunistic disinhibition with sexual content. So, for example, sexual comments or inappropriately like touching a patient when they encounter someone. So this is context dependent. This can be caused by frontal dysfunction, which of course is a hallmark of bvFTD. Now, truly hypersexual behavior involves a dramatic increase in sexual desire and the frequency of sexual acts. And this is much less common, but it's still present in about 13% of bvFTD patients. And some authors associate this type of hypersexuality with dysfunction in the right anterior temporal lobe. AFTD has excellent information on this particular symptom, which you can see here, and I encourage you to talk to your care team. Don't be shy. We know that this can happen, and we may be able to provide strategies depending on the specific type of hypersexual behavior. Okay, next slide. So in general, severity of disinhibition is associated with atrophy or dysfunction in what we call the orbital frontal cortex, which is the bottom part of the frontal lobes. So some research believes that different types of disinhibition are subserved by different networks. So for example, general impulsivity may be related to damage in frontal areas and their connections, while rude or insensitive comments may be associated with dysfunction in the right anterior temporal lobe. Next slide. All right, so apathy is the most common initial symptom in bvFTD, and it appears to be more pervasive and severe in bvFTD compared to other dementias. Now, it is defined as a loss of interest, drive, or motivation, and can also present as passivity or decreased initiation. So these patients need prompting to initiate or complete basic activities. Now, apathy is often mistaken for depression, but pure apathy is rarely accompanied by what we call dysphoric mood, that is, feeling sad or blue. Clinically, that's a very important distinction. We have many patients that come to us with a diagnosis of depression, not because they're sad, but because they basically stayed at home and watched television all day, for example. Next slide. So once again, we know that apathy is not a unitary construct and may depend on deficits in initiation, in planning, and motivation, each with their own anatomical correlates. Next slide. All right. So patients with bvFTD may also exhibit a loss of sympathy or empathy. And loss of empathy refers to the inability to read the emotional expressions of others or imagine their experiences. Now, it is a common feature at initial presentation, and it is also very specific to bvFTD. It normally doesn't happen in other disorders. So loss of empathy can manifest as diminished responsiveness to other people's feelings or a general decrease in social engagement. The patient seems distant, cold, has poor eye contact, etc. So as an outsider, it's hard to know what a patient is feeling. So we tend to say that this feature is present only if we hear specific examples that reflect a lack of understanding or indifference to the feelings of others. So for example, hurtful comments or a disregard for someone's pain or distress. We often hear stories of families realizing that something is really wrong when a family member got hurt or is in the hospital and the patient made a joke or doesn't seem to care, which is very salient because it's so uncharacteristic of this normally loving, caring person. So this particular symptom can be psychologically devastating, obviously, for families, and it is important to identify it as a symptom of a brain disorder, not a reflection of how the patient feels or felt towards you. Next slide. All right, so again, there seems to be at least two main components to empathy, affective and cognitive empathy, each with different areas affected. But in general, we think of loss of empathy as associated with atrophy in the inferior frontal cortex and the right anterior temporal lobe. Next slide. So perseverative compulsive behaviors are also typical of bvFTD, and these range from simple stereotype behaviors such as tapping, touching, scratching, picking, to complex repetitive behaviors such as compulsively going to the bathroom, counting and cleaning rituals, ordering, collecting, or hoarding. Now, patients with bvFTD can also habitually repeat words, phrases, or entire themes. That is, they say the same thing over and over again, even though it doesn't aid in communication. Next slide. Once again, there seems to be a neural dissociation between simple and complex perseverative behaviors, with simple repetitive behaviors associated with deeper structures and more rigid, complex compulsive behaviors with atrophy in the right anterior temporal lobe. Next slide. All right, so hyperality and dietary changes are also typical of bvFTD, and it's not unusual for a patient to gain 30 pounds in a matter of months, given this newfound craving for sweets and other carbohydrates. Now, when the temporal lobes are involved, patients may exhibit food fats. That is, they will only eat certain types of food, often at very specific times of day. In extreme cases, hyperality may manifest as consumption of inedible objects. Next slide. And again, the degree and the type of hyperality will also depend on where the atrophy is in the brain. Next slide. All right, so I'm going to briefly talk about a behavioral symptom that is not actually part of the diagnostic criteria, but we clearly see it in bvFTD, and that is anosognosia. And anosognosia is defined as a lack of awareness of one's condition or a lack of insight. That is, the person with bvFTD may not recognize that they have a brain disorder and that their behavior is affecting their function. Now, anosognosia makes it very difficult for a patient to get diagnosed or evaluated because if they don't recognize what's happening to them, like why to go to the doctor if there's nothing wrong with you? Now, why is anosognosia not part of the current criteria? Well, lack of awareness is not absolute. So for example, when I ask my patients why they're coming in for an appointment, some will tell me, well, it's because I have FTD, and they will go on to describe what the doctor told them and what their wife thinks it's a problem. So in a way, they do know what's happening, but the real issue is that they don't seem to care. They are not as concerned about what this means for them or for their loved ones. So in the beginning, this is very difficult to recognize for families and providers because our minds usually go to, well, maybe he or she is in denial, as in psychological denial, which this is not. It is the product of a brain disorder. By extension, it is important to understand and accept that your loved one is not doing this on purpose. They're not being difficult. They're not being deceitful or manipulative. They are simply not aware or concerned of their changing behavior. You cannot convince a person with bvFTD who lacks insight that they have a problem. What we need are strategies that change the environment rather than the person. Next slide. All right, so although we consider bvFTD primarily a behavioral disorder, It is also a cognitive disorder, and measuring these cognitive changes can be very useful for diagnosis. Now, given that FTD affects the front part of your brain, it tends to disrupt what we call executive functions, and that includes things like initiation, planning, problem solving, inhibition, abstraction, and mental flexibility. Next slide. So the pattern of cognitive deficits in bvFTD reflects the pattern of atrophy. That is, they present with executive dysfunction in the context of relatively preserved memory and visuospatial abilities. Now, if you remember my first slide, this cognitive pattern makes sense as the atrophy is predominantly affects the anterior part of the brain compared to the middle and posterior parts of the brain. Next slide. All right, so now that you have a sense for what bvFTD looks like, I'm going to talk to you about formal diagnosis. And diagnosis is done with the aid of diagnostic criteria, which is basically a guide or a checklist of symptoms. Next slide. All right, so first, in order to be diagnosed with bvFTD, a person must show progressive deterioration of behavior or cognition. And in order to meet possible bvFTD, the patient must also present with 3 of the 6 features that we already discussed: early disinhibition, apathy inertia, loss of sympathy or empathy, perseverative compulsive behaviors, hyperorality, and a neuropsychological profile consistent with bvFTD. Now, why 3 of 6? Precisely because the presentation of bvFTD is highly variable. So some patients may present with very overt behaviors, such as disinhibition and compulsive behavior and hyperorality, while others may be more apathetic or cold or dysexecutive. So it all depends on where the atrophy is and how far along the patient is in their disorder. Next slide. Now, we say that a patient has probable bvFTD when we have imaging findings that are consistent with the syndrome. But we can only say that a patient has bvFTD with definite FTLD pathology if we get to see the brain under a microscope, or if we have the syndrome and we know of the presence of a known genetic mutation. Next slide. All right, so let's talk about navigating symptoms. Unfortunately, although there are promising agents in the horizon and lots of very exciting clinical trials, there are currently no approved treatments that alter the cause of FTD. So management is therefore directed at minimizing symptoms and helping patients and caregivers cope with the disorder. All right, so we're going to talk about general management strategies such as education and seeking support, and then we'll move on to more specific strategies to manage problematic behaviors and executive dysfunction. Next slide. All right, so the first and most important thing that we can do is what AFTD does so well, and that is education. As most of you know, an FTD diagnosis is a long and difficult journey. It is relatively rare, and there are a few clinicians that can take this seemingly disparate constellation of symptoms and make a diagnosis. But once you have that diagnosis, education makes it easier to accept that these behaviors are a symptom of a brain disorder. They are beyond your control and their control. So you're both doing the best you can, right? In a similar manner, no amount of logical argument will get the patient to change their behavior. So don't argue with your loved one. This will only cause frustration for both of you. So instead, redirect, distract, divert whenever possible, and we'll talk about this in a minute. Now, education is not only for patients, but also for providers, extended family, friends, and even the public. And AFTD has ready-made checklists like the one that you see here and information cards that can make this education and disclosure easier for you. So please go to the website and check them out. Next. All right. So seek out support and resources from the experts. Obviously, here in the US, we are lucky to have AFTD, but I also include information about FTD associations in the UK and in Australia. Now, these organizations provide basic, high-quality information about diagnosis, about research opportunities, and very importantly, can connect you to caregiver support groups. You can also check the website for the National Institutes on Aging, which has updated information on FTD. Next. All right, so if possible, get connected to specialized FTD centers. They can also provide resources and conferences that educate caregivers and patients about their disease. Patients who are interested in research may also be referred to research groups such as the All FTD Research Consortium here in the US and the Genetic Frontotemporal Dementia Initiative, GEMFI, in United Kingdom and in Europe. Now, these research groups can refer patients to relevant clinical trials and often provide the best infrastructure to identify and counsel patients with familial FTD. Next. Build your team. Your neurologist can help. These professionals include occupational therapists, speech therapists, social workers, psychiatrists, nurse practitioners, and physical therapists. All of them can offer different valuable insights into the needs of the person with bvFTD, and they can also provide techniques to maximize abilities and extend independence. Now, caring for a loved one with FTD is not something that a person can do alone. It really takes a village. Your family and friends may want to help, but really don't know how. So we often encourage care partners to ask for specific help, like, can you watch a movie with them this Thursday at 5 so I can run some errands? And there are apps for that. This is just one example where you can use a care calendar to organize your care team and activities. And this is just one of many examples. All right. Next slide. So I know that some of you are new to the diagnosis, and here are some of the general steps that we recommend you take as soon as possible. Now, this is a progressive disorder with a very particular set of symptoms: lack of insight, impulsivity, and poor judgment. So with that in mind, you need to plan ahead and prioritize actions that ensure the safety and will minimize risk for your loved one and your family. Again, some of these issues may not be relevant to your loved one, either because of their presentation or where they're at in the disease, but in general, focus on safety. Do this proactively before a crisis occurs. So remove or lock away anything that might be dangerous: firearms, power tools, dangerous appliances. Supervise medications. To give you an example, even mild patients may be lax with diabetes medications, for example, not because they forget, but because they are not as concerned about the consequences of not taking it. Some patients tend to roam or wander. So if you're concerned about a loved one getting lost, look into some form of GPS monitoring. Like, there are apps like Track Your Phone that can help you with that. Now, for patients in advanced stages, make sure that your home environment is safe to reduce the risk of falls. All right, so driving. Driving is one of the most difficult conversations that we have with patients, but it really does need to happen early. As a rule, we want to preserve a person's independence, but we also acknowledge that impulsivity, poor judgment, and a loss of mental flexibility can lead to accidents. And disinhibition can lead to things like speeding, rule violations, and even, episodes of road rage. Your healthcare team can help you with that decision. We can recommend either an independent driver's evaluation or that the patient with bvFTD stop driving altogether. Be aware that there are state laws regarding driving when there is documented cognitive impairment. So this is all about keeping your loved ones safe and protecting you from liability. So as soon as you can, consult an attorney who specializes in elder law, so that you can complete legal forms, including durable power of attorney, healthcare power of attorney, and advance directives. It is best to complete these forms early when the patient can still participate in the process and choose the people that they trust to make these decisions on their behalf. This is particularly important for finances. Now, we have heard so many stories of heavy financial losses, even bankruptcy, because of impulsive buying, gambling, or poor investments. Make sure you can control access to financial accounts and credit cards to prevent this from happening. For example, you can use things like rechargeable gift cards to monitor and limit spending. Next slide. All right, so let's talk about specific behaviors. Again, given that patients present differently, management strategies require an individualized, person-based, and tailored approach. Okay, so first, pick your battles. You cannot target and modify every behavior change. Again, prioritize and focus on safety. For example, some patients may like to pace the backyard in a particular pattern. If this is really not distressing or is a safety risk, you may not want to target that behavior in particular. Second, be aware that this is a progressive disorder. So what worked for a while may not work again. You need to be constantly reevaluating your strategies. All right, so the first step to understanding and managing behavior is to record it as it happens. So in some situations, you may be able to identify specific factors that consistently lead to certain behaviors. To give you a very simple example, a loud television may cause a patient to get agitated. Once you turn the volume down, the person calms down. So now that you've made the connection, you know how to modify your environment to prevent this particular behavior. Sometimes the cause of behavior is not so easily apparent, so you need to play a bit of a detective. It helps to have a log of these behaviors and ask very specific questions. What exactly was the behavior? Who was there? When did it happen? Where did it happen? Why did it happen? Were there any potential triggers? What strategies did you try? What worked? What didn't work? So AFTD has a very useful behavior tracker that can guide you in this process. This particular log is based on the DICE model. There are many models, but this is a very good one. It's describe what happens, investigate possible causes, create a plan, and evaluate the plan. The behavior tracker has the added benefit that you can share it with your doctor and with your care team, so all the members of your care team are on the same page. Next slide. And again, because every person is different, any strategy to change behavior needs to be tailored to the individual. With that said, there are some basic principles to manage problematic behaviors. All right, so inappropriate behaviors often happen because a patient is overwhelmed or unable to understand or navigate their environment. So you can minimize the cognitive demands and anxiety of this by making things simple and predictable. In other words, to the extent possible, create structure and routine. For example, have a consistent daily routine with specific times to eat, to rest, to exercise. Try to incorporate pleasant, structured, simple activities at specific times of day. These activities need to be tailored to the individual. They need to take into account any cognitive, behavioral, physical limitations, and they need to be personally enjoyable. So something that gives them a sense of calm or accomplishment. Now, use a dry erase board to create a daily schedule of routines so that the patient can refer to it during the day and know what is happening. If possible, take advantage of adult daycare programs or companions. We know by research that problematic behaviors decrease if a person is active and engaged. Now, avoid overstimulating, confusing environments. Obviously, easier said than done. It is much easier to control the environment when you're at home, but when you're outside, all bets are off. So plan ahead for transitions or changes in routine. So for example, if you have to go to the doctor, try to schedule an appointment at off hours or ask for quiet areas for breaks. If you're worried about disinhibition in public, print out an AFTD awareness card. This you can give out to other people. They say something like, please pardon my companion, they have a brain disease called FTD. They're not aware that they're making inappropriate choices. Please tell me if there are any problems. All right, so you can also provide cues for behavior that you want to increase. So for example, if you want to encourage your loved one to get dressed, lay out the clothes in the order that you want them to do it, and then you can prompt them and give them directions. Conversely, remove cues for behavior you want to decrease. So a lot of behaviors in FTD are actually behaviors of opportunity. If you don't want them to drive, hide the keys. If you don't want them to eat sweets, store sweets, and in an unusual space, say instead of the pantry, the laundry room. Now, remember that your loved one has limited insight and control into their behavior. So therefore, don't argue with them, don't use logic, rather try distraction or redirection, hopefully to an activity that they find enjoyable, like listening to music or watching a favorite show or taking a walk. You may also need to get creative and look for substitutions. For example, you may substitute sweets with more acceptable alternatives, pretzels or gum instead of M&Ms. Actually, gum works really well. Next slide. All right, so how can we use these principles to manage executive dysfunction? As we stated before, try to create structure by providing simple and a predictable environment. Develop and practice routines and plan ahead for changes in routine. Establish clear priorities for completing tasks. So make sure that the most important tasks are completed first. Break activities into small, tangible tasks and complete one activity at a time. Switching between tasks may lead to confusion and is difficult for patients. Allow more time to complete tasks. Establish realistic deadlines. And optimize concentration during important tasks by eliminating distractions. For example, turn the TV off, make sure there's no background noise. Provide directions in a clear, direct, and concise manner. Next. And you can also use external compensatory strategies to manage executive dysfunction, such as calendars, notes, lists, and phone alarms. In particular, use checklists. Patients can learn to check off activities and to refer to these checklists when they're stuck so that they can go to the next step. You can also place a dry erase board with the day's activities in a visible position. And that board can also be used for essential like to-dos and reminders like check for your wallet. Finally, designate a memory place or a container for frequently used items such as wallet, keys, glasses, etc. So this is just an example of the many strategies that we can use to navigate behaviors in bvFTD, and AFTD has a lot more examples of these. All right, so that is all I have for today. And I hope this talk has been useful, and I encourage you to learn more by engaging with AFTD and with affiliated healthcare professionals. We are here to help. And with that, I would like to thank all of my collaborators, next slide, at the FTD Center in the University of Pennsylvania, and obviously families, our sponsors, and thank you for your attention.
Thank you so much, Dr. Rascovsky, for this very informative and helpful presentation. We just know that, understanding these symptoms and how they coincide with the brain is really often key, how we learn how to approach the symptoms and support the person with FTD. Before we take questions, I would like to just share a few other AFTD resources to support those of you here in the webinar that are navigating these symptoms. And if you haven't already submitted a question yet, but you'd like to do so, please use the question box. So first, as I mentioned, I am one of the members of our helpline team. So, if you were dealing with an individualized situation today, you have more questions, know that our helpline is here for you throughout the journey. If you're looking for information, resources, and support related to FTD, you can reach out to us by phone or by email. And there is also a form that you can complete on our website. So this is another resource for you as you leave today. Next slide. And we really know one of the most valuable resources for people in this journey is to connect with other FTD care partners, other people on this journey who really can understand some of the things that you're experiencing. So we do have a network of support. We have a great tool on the website where you can search for support options. And again, you could always reach out to us on the helpline and we can help you find an option that works for you. Next slide. And then this is a nice long list of resources, many of which Dr. Rascovsky mentioned throughout her presentation. And just so you know, so you don't have to go looking from the website, you will receive an email after this webinar with links to these resources, along with a recording of today's webinar. But if you are watching this after the event recorded, you can always reach out to us in the helpline and we'll be happy to help you find the resources that were mentioned today. And with that, we will begin the Q&A portion. And just to get us started out, I do have a question, just something that I know we often do get asked about on the helpline. So we know that, spouses, partners, or those living with the person with FTD can often, see really significant changes and symptoms, at home with the person when they're spending quite a bit of time with the person. But then the person can sometimes really present quite well in other situations, like in public, sometimes at jobs, even a doctor's appointment. So could you share a little insight, into how, a person's symptoms might vary depending on the place or the situation?
Absolutely. And that is one of the most difficult parts of diagnosis because sometimes you see a patient, for example, in the context of a doctor's appointment or a very structured cognitive evaluation, and you really don't get to see the behaviors that they show when they're in public or when they're at home. And that is because some environments are very structured. So, for example, a cognitive evaluation in a very quiet room where I'm telling a patient, do this, do that, do that, they might just respond and you might not be able to see kind of this difficulty inhibiting responses or with planning or with organizing because I'm providing the structure. Right? But in unstructured environments, that's when you see the behaviors. So that's why it's important when you're going in this diagnostic journey to have this log of behaviors so that your doctors who do not get to see the patient every day or at home can see very specifically, this is what they did. This was the behavior, it occurs this frequently, and that really helps, as you can see, with diagnosis.
Great, thank you. And I'm going to just ask one more from the helpline that we've often hear, and then I'll dive into some of the audience questions. So I think we often hear, people trying to think back, we know there's such a delay in a diagnosis, and then they're often trying to think, when did this really start? And sometimes this is to try to better understand, situations, decisions, or statements the person might have said in the past that might have caused relationship issues and changes. So we know it's really difficult. We can't, pinpoint, when did this start? But can you share any insight, into some of the very early changes and how subtle, they can often be?
Yes, and again, this is very what makes diagnosis so difficult. They are changes in behavior that can often, happen. For example, if a person is anxious or depressed or going through a difficult relationship. So they, unless as I said, they are very salient or uncharacteristic. Sometimes it takes a very long time for the family and for their loved ones to realize this is not normal. This is more than us having marital problems. This is more than a conflict. And usually it's the very specific symptoms that we look for to make that determination. So for example, disinhibition and loss of empathy. Those are two symptoms that don't normally occur in other cognitive or psychiatric disorders, at least not in this age range, right? And that alerts clinicians who are knowledgeable about FTD to the possibility of FTD. And I think that as time goes on, we're becoming better and better at trying to figure out when things started, like going back, and how this can manifest. But it's still, a work in progress.
Thank you. Yeah. So I have our first question from the audience. I'd like to mention that someone is asking about their husband makes sounds all day long. And if you have any insight into that, is it part of a compulsive behavior, and what may cause things like that?
Yes. So sounds like humming or clicking or making specific sounds with that, those are very typical of bvFTD, and we would consider them a simple perseveral or compulsive behavior. And they're difficult to stop. But again, if it often, these repetitive movements in a lot of disorders, it seems like they have a calming effect in a way. So if it is not very distressing and it's definitely not affecting safety, you might want to just focus on other symptoms that you can target. I mean, of course, I know that this is difficult, but it is part of the disorder.
Thank you. Yeah, yeah. And this is a question of someone that is in the process of diagnosing FTD, either through an evaluation process. He said, my loved one doesn't fit the primary disinhibition definition, but she started talking in a baby voice, becoming more childlike in her interests and saying things that are awkward in social settings. Could this be a part of disinhibition?
Absolutely. It is one of the things that we often hear is that a person is more childlike, has reactions that you would expect from a younger person, or makes silly comments or silly jokes. And it's difficult because it's more subtle, but we would consider that part of disinhibition.
Mhm. Yeah. And I think you talked so well about how it really can present so differently from person to person.
Mhm.
Can mobility be affected by bvFTD? Sometimes my mom gets stuck and can't move. When we try and help her get up, she yells at us and says it hurts. But once she's up, she's fine.
Mhm. Yes, so as we discussed when we saw the Venn diagram of overlapping syndromes, some of the syndromes that happen in FTD are movement disorders. It depends on where the atrophy is. And there are different types of movement disorders that can occur. It also depends on where the patient is in the course of their disease, because, as it progresses, it inevitably is going to lead to more inertia, more apathy, and less movement. So definitely talk to your healthcare providers, talk to your neurologist so that they can evaluate what is causing these seeming movement symptoms, and if there are medications or something to help.
Mhm. Great, thank you. I think we've got time for maybe one or two more.
Okay.
I think you did touch a bit about this, but if you can just share maybe a little more, can a person have multiple types of FTD? And I think you did sort of touch on this now
Yes.
too,
Uh-huh.
but they're
Yeah,
asking
but
specifically, yeah, about how there can be that overlap over time, but
yes.
bvFTD and yeah.
Absolutely. And as we discussed, it is these proteins in the brain that cause loss of neurons and atrophy. And it depends on where the atrophy is, what we see. And sometimes there is overlap. And we know that certain syndromes are more likely to overlap. So for example, the semantic variant of primary progressive aphasia, where you have difficulty kind of understanding language and losing the meaning of objects and words, that can overlap very significantly with behavioral variant FTD. So some of these like disinhibition and compulsivity, that is very tied. Whereas, with a non-fluent diagrammatic variant, it is not often seen unless, the person is more progressed in the disease. We also know that movement disorders can occur with bvFTD, in particular ALS. There are some cases of behavioral variant with ALS. So it is just important to communicate all of these different symptoms to your healthcare providers to see how you can best manage them.
Thank you. And let's see if we can grab one more. I think I've seen a few questions, so maybe I could just kind of try to put these together.
Mhm.
If you can share any, background generally about progression or stages. I think this is a
Mhm.
question we often get to. Are there really stages in bvFTD, or what does this look like?
Yeah, I think, it's very hard. It's not because it's so heterogeneous, so different in every patient. It's difficult to um, come up with a staging system like you have, for example, in Alzheimer's disease, where usually it starts with memory and then you have other functions and then you do this. It really depends on where the atrophy is and the conjunction of syndromes that happen. So the survival rate, for example, is very heterogeneous. It depends on how it starts and whether there's movement symptoms. We know, for example, that if ALS is present, if it's combined with some of these syndromes, it does tend to shorten survival. So I would say that in terms of staging, it is more about function, right? Like, how can they function in their day-to-day lives? Like, in the mild stages, they can still function relatively independently. And then in the more moderate and severe, they need more help, even for basic activities of daily living.
Mhm. Right. Yeah, that's a good way to think about it. Yeah, but always a hard question to answer. Yeah. Well, I thank you so much. I know there are still a lot of questions that we didn't get to today, and again, knowing that our helpline is a resource, and we will be sending out the resources that were shared during the presentation today, along with the recording, so you'll be able to refer back. But I just want to share one more announcement before we wrap up for the day. And thank you, Dr. Rascovsky, very much for your
Of
time with us
course, thank
today.
you.
Thank you. So I just want to announce our next webinar will be on October 31st, and it will be focused on diagnosing primary progressive aphasia. And our featured presenter will be Dr. Marcel Mesalem of Northwestern University, one of the world's leading experts on PPA. This will be an AFTD healthcare professional education webinar. CME credits will be available for professionals who watch the webinar live. Stay tuned to your email for more information. And thank you all for joining us today. Thank you again to Dr. Rascovsky for sharing her expertise. If you have any additional questions or comments about today's presentation, please reach out to us. Our helpline contact is right here on the screen. We would love to hear from you. Thank you.